I had SNF's payment methodology under the new Pdpm model. A little timeline here. CMS in 2017 used a model known as the resident classification system, which was criticized by many, including the APTA. Arguments were made that this system did not adequately understand the effect of comorbidities, had a poor set of patient characteristics, devalued us as physical therapists, and even discouraged our use, but most importantly, reduced therapy for those patients who needed it the most. So in July 2018, CMS issued a final rule for 2019. The rule includes plans to replace existing SNF case mix methodology, known as RUGs, with new patient-driven payment model. So this model shifts payments away from a fee-for-service to more of a prospective payment system, and it's to be fully implemented by October 1st, 2019. So on resident classification under this system, there are 10 clinical categories that CMS believed represent residents most often found in SNFs, with 4 collapsed PT/OT clinical categories. Providers are also able to check any boxes of surgical procedures that occur during hospital stay that will provide a better picture of patient characteristics. Functional status has also changed under Pdpm. The new functional score for PT and OT payments are based on items that comply with the IMPACT Act. It's Section G is replaced with Section GG to calculate functional score for resident classification. Each item is scored from 0 to 4, and then a total range is from 0 to 24. Under the previous RUG system, points tracked dependence of patients versus the new Pdpm model where it tracks independence of patients. So due to this, an increasing score does not always correlate with higher payments as it did under the previous RUG version. Case mix groups, residents will then be assigned to one of 16 PT/OT case mix groups based on their clinical category and their functional score, rather than one of 66 under the previous RUG version, which is quite a bit less. Once assigned a case mix group, they will then be assigned an index, which varies between PT and OT and helps in the payment system. The variable per diem rate is also new under Pdpm. So CMS said that constant per diem rates do not accurately check changes in resource utilization throughout a resident's stay, and may actually allocate too few resources for providers at the beginning of stays. So after looking at utilization records, they determined that PT/OT costs actually decline. The per diem rate only applies to PT and OT and the non-therapy ancillary components, which are medical supplies and drugs. The adjustment follows a schedule based on the amount of days a resident stays. It's approximately a 2% decline at day 21 and then continues to decline every 7 days thereafter. So a single payment for resident is based on the sum of the 5 individual components seen there on the left. Payment for each component is calculated by multiplying the base rate by the case mix index and then also by the variable per diem rate for, again, only PT, OT, and non-ancillary services. The payments will then be added together to create a resident's total SNF per diem rate. So a little bit about how this affects PT. APTA believed that the 4 collapsed PT/OT categories could categorize many of the complex patients often seen in SNFs into case mix group that would not fully represent their clinical condition that would warrant our services. So they suggested that CMS account for these comorbidities, which ensure patients who have conditions not reflected within ICD codes but still need therapy would be categorized into most appropriate groups. But the CMS responded and said they did not believe comorbidities play a big role in PT and OT and did not add that change. The variable per diem rate could also cause issues. It could cause reduction in staffing due to reduced reimbursement for PT services after a stay of 20 days, and also put more pressure on the PT from administration to discharge patients before day 21 in order to prevent the loss of reimbursement. Assessments are also new. CMS only now requires 3 assessments to make documentation more streamlined and easier to understand compared to RUGs. The 5-day assessment, which is essentially an eval, discharge, and the interim pay assessment, which is optional and only to be completed when providers determine there has been a significant change in a patient that would require new prospective payment assessments. Obviously, this creates less paperwork and documentation for us, which allows more one-on-one time with patients, and also may boost productivity, which we know is a big thing in the SNF world. Concurrent and group therapy limits. Concurrent is defined as one therapist with two patients doing different activities. Group therapy is one therapist with four patients doing the same or similar activities. So under RUG, there was no limit on the concurrent therapy, but there was a limit on the group therapy with less than or equal to 25% of therapy provided during a complete session. But under new Pdpm, there is a combined limit of less than or equal to 25% of concurrent in-group total minutes throughout the patient's stay. So APTA said that this hinders the ability of a PT to make professional judgment to determine a combination that is most appropriate for patients. Large SNFs whose PTs widely use concurrent therapy will have to be able to adjust to these new limits, but also be able to best decide who on their caseload will be able to participate in concurrent group therapy. So example from my clinic, a lot of my patients were vastly different and able to complete concurrent group therapy, but with the variable per diem rates, we need to be able to make the best use of concurrent therapy in order to make up for lost funds under the variable per diem rate. Interrupted stay. So this is put in place to reduce incentive of providers to discharge patients and then readmit them in order to reset the variable per diem rate. So if a patient is discharged from a SNF and readmitted to the same SNF no more than 3 days, it's considered a continuation, in which case there's no new assessments and the variable per diem schedule continues. But if a patient is discharged from a SNF and readmitted to the same SNF more than 3 days after the discharge, a new assessment is required and the variable per diem schedule resets. So in this case, it reduces burden on us as PTs to have to complete a new patient assessment for each readmission from a hospital. But if it's considered continuation of care, the decline in patient may not be able to be taken into account. So variable per diem rates continue even though a patient now requires more services.